Hey everyone, welcome to another edition of the GWU Dermatology Translational Science Lecture Series. This is our final one of the academic year, this is a special kind of continuation from our Derm Room CDC as a Derm Room grand round, and I'll tell you about our speaker in a moment. I first would like to thank our solo exhibitor sponsor, Novartis, any opportunity. I also want to thank Pfizer for our unrestricted research grant to help build up our Derm Room programming here. I also would like to thank Kaylee, who wears many hats when it comes especially to our Grand Rounds program, from videographer to travel agent to psychiatrist for me. So I really appreciate that. And now to our visiting speaker, Dr. Benjamin Chong. He's an associate professor of dermatology and is the current recipient of the Anita Gilliam Professorship in Dermatology at UT Southwestern Medical Center. He's currently director of University of Texas Southwestern Connective Tissue Disease Clinic and medical director of Parkland Hospital and Health System Dermatology Clinic. Dr. Chong conducts clinical and translational research in cutaneous lupus. He in fact has a NIAMS R01 grant, which is exceedingly impressive, and of course is the golden apple of all physician scientists. He's received funding from Derm Foundation, American College of Rheumatology. The list certainly goes on, and he's heavily published. Just an aside, I met Ben at the SID summer or early summer retreat for rising academicians as residents, and they had us in this compound in the middle of nowhere, like Virginia. You couldn't go anywhere. It was pretty much between going to lectures and drinking on this on-site bar and playing darts. And actually, that's the only part I remember is us playing darts together. Not sure what they told us, but it must have worked out, because it sounds like things are going okay for you. So obviously, no question, Dr. Chong will be talking to us about cutaneous and systemic lupus. Thanks for being here.
Well, thank you, Dr. Friedman, for that kind introduction. It's really a nice pleasure to be back. I'm always happy to come back to DC. I actually was born here many years ago. I won't say how long, but so it's always nice to go back to my roots here. So before I start, I wanted just to go through my disclosures. None of these are really relevant to what I'm going to be talking to you about, but I do just want to make sure I mention that. Okay. So as many of you guys know, cutaneous lupus comes in a lot of different forms, and it can be pretty challenging even for me sometimes to just diagnose it just without really having accompanying tests. So, many of you are familiar with kind of the presentation of this form of cutaneous lupus, the discoid lupus, and then other forms you can see these kind of annular polycyclic plaques consistent with subacute, and then there's also other variants, rare variants of like bullous lupus. So what I'm going to go through today is just kind of go through an overview of subtypes of cutaneous lupus, what the workup and treatments are, talk to you a little bit about current clinical trials going on in cutaneous lupus, which has been somewhat pretty exciting about that. I'm going to talk a little bit about the sort of relationship between cutaneous lupus and systemic lupus, which is one of the things that our group has been interested in looking at, and then I'll talk briefly, if I have time, about our registry. Oh, I'm still, okay. So I'm going to start off with the patient case, since I think most of us are drawn to this as well. So I wanted to firstly have a 57-year-old African-American female who had a rash on her face with complaints of joint pains. The rash itself would seem to get worse from joint exposure, and she wasn't on any current medications, and sort of the labs were mostly significant for a positive ANA and then also a positive RNP. And so she has these, I don't know if this comes out well, hopefully it does. So she has these kind of lesions that are mostly hyperpigmented, somewhat erythematous patches that are present in kind of that malar distribution that we think of in the cheeks. So how many of you, just a show of hands, thinks this is a presentation of acute cutaneous lupus? Thoughts? Okay. Discoid lupus? And then subacute. Boy, no one wants to commit here. Come on. Okay, we had one vote for acute. Let's try again. Acute. Okay. Discoid. All right. And then subacute. Okay. All right, so we're going to go through all this, okay? So subtypes of cutaneous lupus. So I was fortunate fortunate enough to be in an institution where there's quite a rich history of cutaneous lupus. And I actually didn't know this when I came to this institution about 11 years ago. And this was actually established by my predecessors, Jim Gilliam and Rick Sontheimer in the 1970s. And this classification is basically built on the chronicity of disease. So there's acute, subacute, and chronic. And they also really were the first ones to really describe subacute cutaneous lupus from a case series of 27 patients that they saw at our county hospital, Parkland Hospital. And they found that that was also associated with the anti-Ro antibody as well. So this is just a old Grand Rounds pamphlet that Dr. Gilliam actually prepared for Medicine Grand Rounds in 1975. And in this Grand Rounds, he actually prepared this 44-page booklet, which I'm thankful that you guys didn't ask me to do for this part. But it describes actually the different classifications of cutaneous lupus, as well as talking a little bit about what the lupus-specific and non-specific skin lesions are associated with that. So acute cutaneous lupus is what we often consider as one that actually is very, that is usually associated with extensive sun exposure without sun protection. It affects the cheeks, nose, and it often has, these are erythematous, edematous plaques that, or papules that often burn or itch, but oftentimes they're just transient, so they usually last maybe days to weeks. And oftentimes, most of these patients are having other symptoms. Oftentimes, when I'm asking them, they're also very achy with their joints, or they're fatigued. So often this is associated with their underlying lupus. Subacute tends to be probably more or less likely on the face, but is usually tends to favor the trunk and extremities, typically in sun-exposed areas. And there are two variants of it. There's a papillosquamous variant, which we'll kind of go through that, and then also a polycyclic or annular variant of that too. And then one thing that also is important to note is in these patients that up to a third of these patients may have a medication that's causing this. So the most common ones typically are thiazide, diuretics, calcium channel blockers, as well as antifungals. So tend to be, for people who are kind of on the, present with this in their 50s or 60s, I often try to do a very extensive medication history, because if you can find that offending medication, you can pretty much help cure their disease. So this is just an example of annular subacute cutaneous lupus. So you can see, typically you'll see these kind of fine scale border with erythema, and then a little bit of clearing in the middle. And oftentimes they can fuse together to form these polycyclic plaques. And again, oftentimes it can be in the trunk, upper trunk areas that we see that more. And then the papillosquamous variant, which often can be also described as psoriasiform, are these erythematous papules coalescing to plaques that oftentimes can be somewhat V-shaped in the upper chest and upper back area. Chronic cutaneous lupus is the final variant that we wanted to go through, but that actually has the most kind of numbers of subtypes under that. Discoid lupus is probably the most common subtype that we see under that chronic category, but there are other kind of more rare subtypes that I'll go through a little bit in the latter slides. So discoid lupus, I think as mentioned before, is something that we see probably the most commonly in our outpatient derm clinics. And it oftentimes tends to favor the head and neck areas, and oftentimes can present on its own. It doesn't necessarily have to be in the context of systemic lupus. So what you'll see in these patients is that it will favor the face and scalp area. These are areas where you can actually see typically hyperpigmentation on the periphery, hypopigmentation in the middle with scarring and underlying erythema. You can have kind of this carpet-tack scale that often you can see, and then you can often see predilection for the conchal bulls here. These are kind of other variants that you might see. Typically, if you see these, if it does present below the neck, that typically has a higher risk for people with systemic lupus, or more commonly seen with people with underlying systemic lupus. So these are just examples of DLE that you can see in the trunk as well as extremities. And then there are other kind of forms that we've also seen over time that maybe are a little bit more atypical per presentation. So instead of the peripheral hyperpigmentation that most people see, you can sometimes get the central hyperpigmentation in the opposite case, and then kind of and then more hypopigmentation in the periphery. You can get kind of a hyperkeratotic variant that I think some people would be concerned about a higher risk for skin cancer in those patients too. And then also you can kind of get a rare variant where you can see it on acral surfaces as well. This is just an example where you can see that on the palms and sometimes also in the soles for severe cases. So what did this patient end up having that we mentioned earlier? Well, when we did a biopsy, it actually ended up being consistent with discoid lupus. So this patient actually ended up having discoid lupus. And what I kind of wanted to mention was sometimes discoid lupus itself can present in malar areas because we sometimes associate that with acute cutaneous lupus, but with the dyspigmentation that can more be present for longer periods of time, that is something that you still need to be aware of that can happen. All right. So another variant of chronic cutaneous lupus is tumid lupus, and it's actually, some studies have shown that it's probably the most photosensitive variant of that based on studies using UVB provocation as well. And these tend to be also kind of in the upper trunk area, face, and usually it's probably the most responsive to antimalarials. So when I see this, I try to actually really push getting antimalarials and try to maximize the use of it before I try to use other oral immunosuppressants. So this is just an example of tumid lupus that occurred in this gentleman's temples as well as lateral cheek areas. And after a couple months of hydroxychloroquine, he did pretty well with it. And even despite his probably lack of photoprotection since he was a motorcycle driver as well. And then there are other kind of variants of tumid lupus that we've seen in skin of color. So this is a patient that I had that had tumid lupus by biopsy, but was a little bit atypical because you can see that, I don't know if you can see that these lesions were papules, but it didn't have the characteristic bright erythema that I usually see. But this actually kind of looked a little bit, maybe a little bit hypopigmented, but I think we felt that actually, that because the amount of edema that was seen under biopsy that may have actually contributed to maybe the lightening of the skin texture as well. And she did really well with this chloroquine treatment with with that. Okay, lupus paniculitis is a variant that affects the subcutaneous fat, and typically they can be usually painful erythematous papules and nodules that actually eventually then become these involuted subcutaneous nodules as well. So you can see in this patient here, you can see that there's quite a bit of involution that has occurred due to the chronicity of the disease as well. And that can affect, oftentimes we've seen it in scalp, face and the cheeks, upper arms, buttocks and thighs is what we usually see. There's kind of a rare variant called lupus mastitis, which can affect the breast area as well. And then oftentimes these patients will have kind of overlying discoid lupus, which we kind of then term it as lupus profundus. So this is just examples of cases where patients have had it up in the scalp as well as in the cheek area. And then I did want to just highlight Chilblain's lupus, which is actually a variant where it typically ends up being favoring the kind of digit areas, typically fingertips, toes, and ears. And this is actually a variant that typically is exacerbated by not heat or UV radiation, but actually cold, and sometimes prolonged moisture as well. And then sometimes I've had patients with this actually where they developed actually discoid lupus as well. And we typically will treat this with, again, antimalarials, and sometimes calcium channel blockers can be helpful in this situation too. So this is an example of Chilblain's lupus where you can actually have involvement of the toes, the digits, usually it's periungual areas, but also sometimes at the tips of the fingers as well. Severe variants can ulcerate, and this is just an example where she did ulcerate and then kind of developed this scar from that as well. And then bullous lupus is a kind of a rare variant where this is actually due to autoantibody deposition, a deposition of autoantibodies against collagen 7. And this can occur typically in the head and neck area, sometimes also in the axilla, and it can also affect mucous membranes. And dapsone is kind of the treatment of choice for these patients as well. And then in terms of workup for patients, what we usually do with diagnosis is basically based on history, physical, and then biopsy, where you can have the characteristic findings of interface dermatitis where you have basal cell macular degeneration, infiltrate of lymphocytic infiltrate that's hugging the epidermal junction, perivascular, and sometimes often perifollicular lymphocytic infiltrate, and then mucin deposition are the things that we're looking for. What we'll typically also do is additional studies. Lab work can consist of looking at a complete blood count, BUN creatinine, an ANA, and a UA as well to look for kidney involvement. And then you can also consider additional studies if you really have a high suspicion for systemic lupus, doing an extractable nuclear antibody panel, which I think you guys have seen already, a double-stranded DNA, which is not part of that panel, but is usually ordered separately. You can also look at inflammatory markers and then complement levels, and then consider specialist referral like rheumatology based on those results. So I usually follow my patients pretty closely depending on how acute they are. So it can be weekly, biweekly, depending on how they're doing. But generally for people who are pretty stable, it can be anywhere between 3 to 6 months or sometimes even a year as well. And then in terms of kind of my medications, I try to like to taper my medications if possible in the fall and winter when they're less likely to flare. So this is sort of my treatment regimen on what we usually consider doing for patients with cutaneous lupus. So I start out in the limited variants, and this is not just limited to limited because we can do this for all types of patients, is we usually make sure that patients are photoprotecting pretty well with sunscreen and then protective clothing, topical steroids, and intralesional steroids. So limited usually are just if these are patients that maybe have a couple lesions that are 2 or 3 lesions that are usually addressable, that can be easily addressed with topical steroids. Intralesional steroids are typically ones that are used for symptomatic relief. And then for kind of a little bit more widespread involvement, our antimalarials are typically our first-line treatment. So hydroxychloroquine is what we start with at 200 milligrams BID. And then we try to once they kind of are under control with that, we go to their we taper that to be in compliance with the American Academy of Ophthalmology guidelines as well, which I'll go through a little bit more later. And then sometimes we'll also consider the other antimalarials, which are quinaquine and chloroquine, which I'll talk a little bit as well. Prednisone can often be used for kind of symptom reduction as well, and we kind of taper that over a course of maybe 6 to 12 weeks as well. And then for more really diffuse or more refractory modest cases, the typical oral steroid-sparing immunosuppressants can be used. MMF is something that we like, methotrexate, azathioprine, and then also the thalidomide and the thalidomide analog lenalidomide can be also used, and dapsone is another treatment option, specifically really for bullous lupus variants. So hydroxychloroquine, I think we've kind of mentioned a little bit already about what side effects are typically involved. GI upset is most commonly involved, but the skin pigmentation is typically also something that you can also see for people who've been on it for a while, and I'll show you some examples of that. And then retinal toxicity typically in patients who, which is usually higher risk for patients who've been on it for a while. Typically the higher, what they say is cumulative dose of 1,000 grams or higher is where their risk is a little bit higher. Generally, the guidelines for this is that we usually recommend getting a baseline ophthalmological examination within the first year of starting hydroxychloroquine. And then the guidelines are after that, after 5 years of use, you can then get yearly exams after that, is what the AAO recommends in this case. So in terms of skin pigmentation, you can get kind of this kind of blue-grayish hue patches with this blue-grayish hue that are most commonly seen in the forehead, upper lip areas, shins, forearms is what we see. We can see the mucosa area too, and then also you can see it also the nails too, where you can. I'm sorry that it may not show very well, but you can get these transverse bands that look that show up also on the nails as well. So hydroxychloroquine, there aren't a lot of studies actually showing this efficacy, but this is probably the best study that's been done showing the efficacy of hydroxychloroquine cutaneous lupus, and this was actually recently published in Arthritis and Rheumatology about 2 years ago in Japan, because actually in Japan, for the longest time, they actually didn't have access to hydroxychloroquine because of the concerns of retinal toxicity. And so in order to reintroduce that medication to Japan, they actually did this kind of, they were doing this actually a randomized control trial of showing efficacy of hydroxychloroquine in cutaneous lupus. So this was actually a 52-week trial where patients were initially randomized to hydroxychloroquine and placebo. Now, placebo was actually not true placebo, but patients who were on kind of really stable doses of their other types of immunosuppressants they were taking. And both of these groups actually did pretty well for the first 16 weeks. So both people who got placebo and hydroxychloroquine actually improved in terms of their disease activity. And so there wasn't, in between time, but there wasn't a whole lot of difference between the two. And then in the final 36 weeks, they actually all got hydroxychloroquine, and they all showed that they still continued to improve when they were getting hydroxychloroquine. And then this was actually a nice study, a meta-analysis study that was done looking at just reviewing 31 studies, looking at the efficacy of different antimalarials to cutaneous lupus. And so what they found was the overall response rate to these antimalarials in patients with cutaneous lupus was about 63%, a little bit higher in people who got chloroquine, about 69%, and then hydroxychloroquine was at 61%. And the response of actually antimalarials did vary depending on the predominant subtype of cutaneous lupus. So people who actually had acute cutaneous lupus tended to do really well with the antimalarials, but those who didn't do well were those with chilblains as well as actually discoid lupus. So when hydroxychloroquine doesn't quite get the response that we see where patients, and we usually have them on for about 3 months, we add quinacrine, which has already been talked about, and that's typically compounded as 100 milligram tablets. And the yellowing of the skin is usually the most common side effect that we see, as well as the sclera. It is reversible if you stop it. And also GI upset is actually a really common condition as well. But we've been having some issues with getting, as I think many of you know, there's been issues with access, and that's been primarily due to, I guess that's been due to actually, I think, the import of this medication, and I guess there have been some, what I've heard is I think there's been some new, I guess, kind of investigations to the supplier that's actually importing this medication right now. So I think that's one of the reasons why this has been in short supply as well. But there's also been consideration from the FDA to actually also limit the availability of this medication too. So that's been a huge issue. So the other option is chloroquine, which we often add. We'll replace people with hydroxychloroquine if that doesn't work. So we don't want to actually have that in combination. You don't want to put people on both chloroquine and hydroxychloroquine because both of them are at high. Both of them are both associated with retinal toxicity, so you don't want to put them on both. Typically, it's thought to be more potent. We usually start them at 250 milligrams. And then get them down to the kind of recommended doses of 2.3 mg per kg per day. That's the ophthalmological guidelines as well. Again, we want to make sure that they probably get a retinal exam within the first year of when they start. But oftentimes, I think they want, most ophthalmologists probably want to watch them more closely than people on hydroxychloroquine. So they may be probably getting a yearly exam while they're on that medication as well. So I kind of already briefly talked about prednisone. Prednisone can kind of be used anywhere from 0.5 to 1 mg per kg per day, depending on the severity of disease. And then often, we keep them on for that dose for 2 to 4 weeks and then taper over a course of 3 months as well. And then pulse IV steroids can be also considered as well. Mycophenolate mofetil is something I often do like to use because of kind of the ease of monitoring and tolerability. We start at 500 milligrams BID and then go up to anywhere between 1,000 to 1,500 milligrams BID. But typically, it is a little bit longer in terms of how long it takes to get people to respond. So we usually try to get them to be at least 3 months, but oftentimes it's longer than that as you are actually increasing that dose up to 1,500 milligrams. One study that came out from my colleague, Dr. Melissa Kostner, about over 10 years ago, they found that patients who their retrospective study of 24 patients with cutaneous lupus on mycophenolate mofetil, all of them actually showed a partial or complete response. And typically, the average dose of these patients actually was close to 3,000 milligrams each day. And on average, it took them almost 3 months for them to show a benefit with this dose as well, or with this medication too. Methotrexate is also a great option for patients with refractory cutaneous lupus, and it's usually anywhere between 15 to 25 milligrams each week. We usually do the oral dosing, but sometimes for better tolerability and also potency, we also can switch into sub-Q doses as well. There isn't a whole lot of data on this. The best I found was actually looking at the intravenous form of methotrexate given to patients with cutaneous lupus, and of course they did really well, but they're actually tolerability, about a fifth of these patients had to DC this medication, the IV form of that, because of side effects issues. So, obviously it's not something that we typically do, but the sub-Q form is something that we often like to do because it can be well tolerated. And then thalidomide has been something that has been looked at extensively, and I think it's been probably primarily used for patients with refractory DLE and sometimes subacute cutaneous lupus. There's a lot of data that comes out of this from kind of not so much from the US, but more from Latin America as well as Europe, where they've extensively used it more. And it can be very efficacious. Typically, some of the patients that people put them are usually at 100 milligrams at night. But however, it is limited by the side effect profile, particularly because of their neurotoxicity, actually really the irreversible sensory neuropathy that people can get, sedation, and then a higher risk for clots can be also considered an issue as well, and as well as the teratogenicity issue. So I think that's one of the reasons why it's probably not used a whole lot here in the States, but it can be very helpful for refractory patients. And the data with this is actually pretty impressive at the 100 milligram dose, where people do really well with this. There's kind of a more, there's a version, a separate alternative called lenalidomide, which is an analog of thalidomide. It's thought to actually have probably a bit more potent than thalidomide in terms of its TNF-alpha inhibition properties as well. The nice thing about this is it doesn't really have the sensory neuropathy issues that thalidomide has. It's been typically used as a medication for multiple myeloma. I have been able to get this for a couple of my patients, but it does require some convincing with the insurances to cover it because of the cost as well. The initial trials came out, or kind of efficacy came out from my colleague Vicki Wirth at Penn, where they found that actually in their small trial initially of 5 patients with refractory CLE, that their scores actually, their activity scores really dramatically improved. Typically, I start at 2.5 and go up to 5. In this study, they went up to as high as 10 milligrams in people who didn't respond. And then probably about 8 years ago, belantamab, which is a biologic that actually targets BAFF, which is a B-cell activating factor that really is important for the stimulation activation of B cells, was approved for systemic lupus and was the first new drug that was approved for lupus in like 50 years. And so this is a medication that is actually typically given by IV, and now there's a injectable form that you can use now. The data, so it's approved for people with antibody-positive systemic lupus patients. I would say that the data for patients with cutaneous lupus has been kind of mixed, and my experience with it has been kind of mixed as well. The data, probably the best maybe data that's shown with efficacy came out of Italy, where patients with active SLE, maybe about a fifth of these patients also had cutaneous lupus, and they found that there was some improvement with their disease activity, although I think it was modest at best. When we actually, when it first came out, when this first medication first came out, we were actually pretty interested in looking at what were its potential for cutaneous lupus, and so we were measuring actually BAFF levels and the receptor levels in skin using PCR and immunohistochemistry. And we found that in patients with discoid lupus skin and in blood, and these were patients who just had discoid lupus only, they didn't have systemic lupus, that it was elevated in their skin as well as their blood. And so that there's maybe potential for potentially topical therapies for BAFF in the patients with that in patients with cutaneous lupus, but I would have to say in terms of just the treatment itself with this, at least the IV form, it has been somewhat underwhelming in terms of patients with refractory cases of cutaneous lupus. Before I go on, I just want to make sure, is there any questions that you guys have in terms of management workup? Or, yeah.
Is tumor lupus really lupus?
That's a good question. So that's kind of a debate because, so where that's coming from is actually because of the pathology, because there isn't, when you're looking at it, there's no interface dermatitis with tumor lupus. And then there's also, because it's also, there's overlap with this with, reticular erythematous mucinosis as well. And Yesner's too, right. So I think I do think that there's still, I still feel like it can fit in cutaneous lupus because I think of its, because we have seen it in a number of systemic lupus patients. So, and so I think I still am kind of in the part where it's actually kind of in the realm of where it still falls in probably the cutaneous lupus variant. It's just it is a little bit different because of the pathology, and then also because it often is recurrent. It has this waxing and waning nature. But I think in terms of when you look at just sort of the pathology of it, besides the interface dermatitis, there's still been data showing that there's still increased, type 1 interferon signature that's seen in these, the skin of these as well. That's kind of also seen in cutaneous lupus, and higher numbers of plasmacytoid dendritic cells that we think that it's still probably part of that, and that's why I think I still consider it as cutaneous lupus.
Do you follow for seroconversion at all, or more you will check ANA based on symptomatology?
So I often recheck ANA if it's based on symptomatology, and so if it's low titer or negative at first, we will consider rechecking it again in the future based on symptomatology. If it's already been high, it's not something I repeat because I don't think it's helpful. It's not a great disease activity marker, not as good as probably the double-stranded DNA that people often use, or the low complement levels. Yes.
So I have a question on pathway though. I get a lot of different information from various attendings and also various textbooks. What do you, other than obviously checking for ocular toxicity, what other labs do you like to check and how often?
Yeah, so I didn't cover it in there. It's going to be in my other lecture. But I will get a baseline CBC, LFTs, B-creatinine sometimes is L, but I don't get a G6PD. I know that there's people that I've worked with attendings who get that. There's really not much data that it actually causes, it's been an issue with people with G6PD deficient patients as well. So I don't get usually a G6PD as well.
Do you follow up this CBC or anything like every month, every year?
Yeah, so the recommendations from most textbooks say, monthly for the first 3 months, and then you gradually space it out to 3 to 6 months or so. So we've done that, but we have really, over the kind of years that we've seen that, we haven't really seen really that much issues in terms of a lot of changes in the CBC. So we might really, I don't know if you have to really be as stringent with it as well, but that's what a lot of the Wolverton textbooks that I read, that's their guidelines, but we haven't really seen it as much. Yes?
There are cutaneous lupus patients when they do have retinal changes, secondary to black now with severe signal plant there.
Well, then we usually have to stop it as well. But there's a lot of, I know that there's, but sometimes it's tricky. Diagnosing retinal toxicity, and this is, can be variable even from specialists, and so because there's actually not a consensus on diagnosing this. There are different tests that people do, but there isn't a consensus of diagnosing this actually, and so that's why there's a little bit of variability with that. So sometimes if I feel like it's really helping them, and someone said, I think there's retinal toxicity, I may actually get a second opinion from a retinal specialist. So for patients who because if they've seen kind of an optometrist or a general ophthalmology, they may not be as well versed in trying to figure out what they need to look for. So oftentimes I will seek a second opinion from a retinal specialist too. But yeah, yes.
So when you send them for their baseline ophthalmology exam, do you specify to the ophthalmologist or optometrist specifics what you want examined? Because it's not
Yeah, no,
part of the regular thing.
I don't usually, because I guess I don't think they'll listen to me anyway. So because they all have their different thing, but typically I do tell patients that I usually prefer them to see an MD, not an optometrist. But most patients they'll do is they'll get like a visual field test. An OCT is typically what people will get. That at least they should be getting, and a good fundus dilated exam is what they should be getting, but they don't always get it. And so, but that's probably at the very minimum that they should be getting as well.
I have a lot of patients on platform. When I refer them, I just simply tell the ophthalmologist that the patient's on platform.
Right. That's what that's what I usually just tell them, and then just make sure you tell your eye doctor you're on hydroxychloroquine or chloroquine. I mean, that's the other thing. Yeah. Yes.
It seems like the trend is to do less direct immunofluorescence. You didn't mention it at all.
No, I didn't. I know.
Nice. I kind of like that. We don't do that. What do you think about that? And also, we did some lupus LP overlap.
Yeah. And so that could probably be more helpful for that. I think for the DIF, that it can be really helpful to sort of differentiate if there is like that overlap as well, or if it's lichen planus as well. I don't typically do a whole lot of it either for diagnosis, because usually it's usually mostly clear from the H&E if it's lupus or not. But historically, people have used it maybe usually as a diagnosis for sometimes with historically I think it has been used for DLE. It's pretty high in the lupus pan test for lesional skin, that there's a high sensitivity for that. Sometimes actually for sun-protected skin, people have done it to actually look for systemic lupus, and that was kind of a historical thing that people did as well. So, but we don't use it a whole lot.
Yeah, I asked a rheumatologist about doing the lupus band and the sun-protected skin. It just seems like once you have serology that we have today, it seems like that would rarely ever be needed.
Right, and it may be supportive, but it's not something, you're right, with the serologies, I think that we usually don't use it as much now because of that, so.
Or in bullous lupus, especially if you can get full split skin,
right,
and you can distinguish where the deposition is.
And I'll have that's in my other talk as well, but yes, that's very true. We will do that in that case, because that can be helpful for the diagnosis too.
And you can always have lupus, pre-existing lupus, which is blister, which is really not the same.
Right, yeah, I didn't go through that, but yeah, that's another one too, because you can have very inflammatory cutaneous lupus where it does blister up, and that's different from the bullous lupus variant, where you can get that, and that can be often in case of acute, right, acute cutaneous lupus. Yeah. Sorry, one more question in the back.
Yeah, I've heard certain people say different things as far as when you put a patient on plaque milk, you need to make sure that you have a baseline eye exam, or you just need to do the eye exam within the first year.
So the guidelines are within the first year. Now, I will ask patients about whether they have a history of retinal issues. So if they've got bad diet, poorly controlled diabetes, macular degeneration, probably not a good idea to start. And so I'll wait to get the ophthalmologist's opinion before starting that. But if those are things that you want to be careful with that. So,
and then what is the frequency with which you recommend that they get ophthalmology exams?
So the guidelines say first year, and then after 5 years, yearly. Now, I don't usually tell them that, because I usually let the ophthalmologist decide that, because if there are other issues that they need to be seen sooner, then you just tell them what did your eye doctor say. So, but if they have no other issues, that they didn't say anything, then that's what I tell people, is that's what the guidelines are. Okay, great questions. So, I'm going to go through briefly the pathogenesis of cutaneous lupus, just to give you some context of where some of these new clinical trials are doing. So many of us know that UV radiation is probably a well-known trigger for cutaneous lupus, but there are other maybe less known triggers. Trauma has been also associated with that. We think that genetics probably plays a role too, and maybe potentially also unknown viruses can also trigger this. And the idea is that for UV radiation, it can actually trigger kind of increased apoptosis in keratinocytes, which then really can trigger release of type 3 interferons as well as chemokines like CXCL9 and CXCL10, which can really lead to activation and recruitment of an assortment of inflammatory cells, and that ranges from T cells, macrophages, which then can go and engulf these apoptotic keratinocytes, as well as plasmacytoid dendritic cells, which are kind of a key player in lupus, particularly because of their production of type 1 interferons, which also then subsequently can activate a lot of other inflammatory cells, cytokine, Th1 cells, cytotoxic T cells. And so the newer treatments that are out there actually are really focused at type 1 interferons, as well as their receptors, as well as plasmacytoid dendritic cells. So the treatments for their biologics that are now being targeted against against interferon alpha, and this is a phase 2b randomized control trial of patients with systemic lupus. And a lot of these trials actually have a subset of patients now with active cutaneous lupus who meet these certain criteria. And so of the patients that had active cutaneous lupus, it was about maybe a quarter of these patients, they were randomized to either getting placebo, 600 milligrams or 1,200 milligrams every 4 weeks. And interesting, patients who actually got the lowest or highest dose actually got more likely to reach treatment response than placebo at the end of the study, which was at week 52. And generally, these patients actually tolerated these treatments pretty well, with infections like URIs and URIs being the most common adverse events as well. And then there's another study that came out maybe a couple years ago, another phase 2b study with a monoclonal antibody against the type 1 interferon receptor itself, which actually showed even better kind of more promising results based on, because the endpoint was actually a little bit more stricter in terms of what was considered to be treatment response, because they had to actually achieve a 50% improvement in their activity score at the end of the study. And so patients who actually got both the 300 or the 1,000 milligram version of this every 4 weeks, actually about 60% of these patients actually reached this endpoint compared to the placebo, which is about 30%. And again, pretty well tolerated as well as that. And then this year, they just started a trial looking at, this is a monoclonal antibody against BDCA2 on plasmacytoid dendritic cells. And this is actually targeting, so this is a receptor that's specific to plasmacytoid dendritic cells. And they just did one IV dose, just looking at their of this medication, just looking at the pharmacokinetics as well as their tolerability. And patients these were patients who had active cutaneous lupus, where they showed that most of them actually showed clinical response, as well as a decrease in their type 1 interferon signature expression in the skin and blood. All right, so I'm going to kind of move towards just talking a little bit about CLE and SLE. And so I think most of us know a little bit about the traditional criteria that's been used for diagnosing systemic lupus. And so the traditional American College of Rheum criteria has 11 criteria for diagnosis for lupus. 4 of them are actually skin-related, the malar rash, discoid rash, and photosensory oral ulcers. And then you have the arthritis that can affect the small joints most commonly. Usually it's more in the morning that they can have that. You can have hematological abnormalities like low white blood cell counts, lymphopenia, abnormalities in their antibodies. Typically, it's the ANA or other autoantibodies like double-stranded DNA and Smith antibodies. Nephritis is often the most concerning of all, because it can be the source of the highest source of morbidity for patients with lupus. Serositis can be seen, where you can have inflammation around the lining of the heart or lungs, and then finally cerebritis, which can cause a whole host of neurological symptoms. So the issue with this criteria is really because of the fact that one of the issues is really because there's quite a bit of skin criteria that's associated with this. So actually there's 4 different skin-related criteria with that, and actually if you have all 4 of them, you could really get that diagnosis of systemic lupus without really meeting any of the other criteria. So what we kind of did in this study was that we actually looked at patients who had primarily skin related criteria who were actually considered what we considered borderline, because really and we actually compared them to people who had clear-cut systemic lupus and people who didn't have systemic lupus. And what we did in this kind of study was actually look at their autoantibody profile based on the ANA, their different antibodies against different extractable nuclear antigens. And what we found was that patients who kind of fit in this borderline profile, where they had a lot of skin-related criteria, really resembled patients who really didn't have systemic lupus. More so than people who had systemic lupus here. And then other things that really were kind of shortcomings of this criteria was just the definitions of photosensitivity often can be very vague, and then also really seen in other photosensitive conditions that we often see. And then also just the vague descriptions of oral ulcers and the fact that it doesn't really account for other cutaneous lupus subtypes of subacute cutaneous lupus. So in about maybe 7 years ago, there were newer criteria that's been developed primarily probably for the use of classification for systemic lupus in clinical trials. So this is the SLIC criteria, which actually now requires, again, 4 criteria to be met, but one of them has to be clinical, and one of them has to be, there's a clinical category, and then there's an immunologic category that they have to both meet. So the clinical criteria here is laid out, just the skin variants here, and it actually has accounts for subacute cutaneous lupus, which was not accounted for in the original ACR criteria. There's a little bit more guidelines about what ulcers are, and then also defines the acute and chronic variant as well. And then it kind of lists the other non-skin variants here. And then it also has a kind of a little bit more extensive list of the different immunologic criteria that's seen in patients with for diagnosis of for classification of systemic lupus here. And then there's now that we are, there's still obviously still more evolution in the criteria that's being defined for SLE. So there are now actually proposed criteria again for systemic lupus that's been jointly proposed from the major rheumatologic societies. So this is from the American College of Rheumatology as well as the European Union for their rheumatology group as well. And so what they're now proposing is there's now weighted criteria based on just the different symptoms that people could have. And if you get a score of over 10 or more, that you can actually have a diagnosis for SLE. So the highest weighted is actually having lupus nephritis. And then there are different, I think they have also consideration for skin lupus as well, with acute cutaneous lupus being higher, getting higher number of points than the other variants because of its association with systemic lupus here. So cutaneous lupus itself really can be seen with or without systemic lupus. And so this is just kind of a figure that came from a nice epidemiological study in Mayo Clinic, showing that the incidence of cutaneous lupus by itself is actually pretty close to the incidence of systemic lupus. So this is not a high amount, but it's about 3 to 4 cases per 100,000 people that they calculated as well. And then they also, in another study done in a multi-center study in Europe, they found that actually patients who, out of 1,000 patients with cutaneous lupus, about 40% of these people already had enough criteria for systemic lupus as well. Now, in terms of kind of progression to SLE, probably about 15 to 20% have been shown to develop from cutaneous lupus to systemic lupus. So this is from the same study I mentioned in Mayo Clinic. They found that in this group, about 13% eventually developed SLE, but it was over a mean time of about 8 years. 8 years that was seen in this group. And then there was a nice larger study done in epidemiological study done in Sweden, where they found that actually a higher percentage of patients progressed to SLE. This was about 18%. They found that females were actually twice more likely to have develop systemic lupus than males. And then also they did this kind of looked at patients with discoid lupus and subacute cutaneous lupus, where subacute cutaneous lupus actually had a slightly higher risk of developing SLE within 3 years compared to the discoid lupus group. Now, Vicky Wer's group actually then looked at their patient groups over at Penn, where they looked at patients who started from CLE and then also developed SLE, but what they wanted to really see was what type of criteria were these people actually getting over time, and were they actually really considered to have mild, moderate, or severe disease. And what they found was a lot of these patients who progressed to SLE really developed mostly mucocutaneous criteria. So most of them were skin-related, or they had also arthritis that developed. And in terms of just looking at their symptoms as well, in terms of just asking what their severity of symptoms was, they were considered in the mild category. Yes, sorry. So this is the severity of disease in this case, and the symptomatology was based on a scoring system called the BILAG score, and this is actually based on what they had a questionnaire that they filled out based on how many different, it's just basically the different types of systemic criteria that or symptoms that they were having, and they have a category of basically from that category, and scores that they develop, they have they categorize between mild, moderate, and severe. So it was based on kind of questionnaire and review systems that they were following patients over time. So that's how they kind of categorize that. Yeah, so, and then on the clinically, what we kind of often consider as the mild variant overall is just really looking at what are the different types of criteria they're meeting in terms of their diagnosis. So what we maybe consider mild is if they mostly still have skin-related criteria, maybe they have a positive ANA. That's probably more in the mild category than maybe on the severe, where they have active lupus nephritis, they have kidney disease as well, where they have other end organ involvement that can be at higher risk for morbidity issues as well. So that's probably where my gestalt is in terms of looking at severity of disease.
We have the PEST scoring kind of questionnaire for psoriatic arthritis, which is very quick and easy. Is there anything analogous in the lupus world?
I think that's kind of like in terms of cutaneous lupus and looking at not so much. That's something that we don't have, but it'd be good to know. I think maybe the best analysis that maybe the best is I haven't really, I might have some time to briefly go through it, is actually just the quality of life questionnaires that we do administer to patients about that, and look at severity of symptoms through just comparing. Actually, what we usually do is we often use the Skindex, which is actually a skin disease specific patient-reported outcome measure that has actually they actually have scales that actually rate them between mild, moderate, and severely impact the life as well. Impact on quality of life as well. So, yeah. So what we've kind of looked at from our group is we've also looked at patients who progressed from CLE to SLE, and we found a kind of similar percentage of patients with that have progressed to SLE, about 15% of them. And again, most of them are kind of on the mild variant, where they really have just accumulated mostly some skin related criteria as well as some more, but they haven't really had the more severe end organ involvement like kidney disease as well. But what we were kind of looking at as well is looking at what also just over time, the question we wanted to look at was looking at variables that can change over time. So in terms of their disease activity, how does their disease activity kind of look over time for these patients who progress to SLE? And what we found was that their disease activity typically over time actually was worse consistently over time to patients who didn't progress. And so one of the things that we found was actually for patients who kind of continue to have refractory disease, they seem to be at higher risk for getting SLE as well in our patient population too. So in terms of just like looking at kind of what can prevent progression of disease, there was one study that came out from the Room literature years ago where patients who, these were military personnel who actually were retrospectively followed over time, who got hydroxychloroquine before their diagnosis of systemic lupus or prednisone. And what they found was that people who got hydroxychloroquine tend to maybe have a longer delay to diagnosis, were found to have maybe a longer progression to systemic lupus than those who didn't get hydroxychloroquine over time. But since this was a retrospective study, really a prospective study would be really helpful. A randomized control trial would be helpful to really look at whether hydroxychloroquine can truly actually prevent progression. So I'm actually part of a multi-center study that's funded by the NIH, looking at whether hydroxychloroquine really can prevent the progression of lupus in patients who are at risk. And so our cutaneous lupus patient population is kind of in that, population, at risk population, higher risk for getting systemic lupus. So these are patients who are being part of this trial to see if whether placebo or hydroxychloroquine can actually, whether there's a difference in progression to SLE in these patients. And so this is a study that we're part of, as well as 4 other sites across the US. This is a 2-year trial that we're part of. Let's see. I got 5 more minutes. Okay, I'm going to actually kind of like, let's see. I'm going to go through, I'm just going to try to see. So there's some emerging literature looking at pediatric cases of cutaneous lupus. And so my colleague Lisa Arkin over at Northwestern actually did a retrospective study looking at 40 patients with just DLE in the pediatric population. Again, they found that about a quarter of these patients actually were later diagnosed with SLE over time. And again, most of these patients who developed SLE, again, had mostly just mucocutaneous limited diseases and abnormal lab tests like an ANA test or a double-stranded DNA as well. We're actually now part of a kind of a multi-center study. Again, kind of getting a larger collection of patients, trying to get a larger collection of patients to sort of validate this study as well. So we've currently now, I think our group has now looked at more than 200 patients, where about 20% of these patients actually progress from DLE to SLE as well. And so we're still going through the analyses as well, but we'll be planning to present this data soon at the American College of Rheumatology meeting this coming fall. All right. So in terms of like what are risk factors associated with systemic lupus progression, we've done some studies looking at this, and what we've found is that patients with generalized discoid lupus, so typically these are the ones that have discoid lesions below the neck, are more likely to have systemic lupus. We've also found that identification of periungual telangiectasias can be at higher risk for that. And then people who develop arthritis typically in the small joints are higher risk, and then also lab abnormalities like a positive ANA can be also considered to be risk factors for development of systemic lupus. I'm going to skip through this a little bit. This is just some data just looking at whether discoid lupus is actually maybe considered to be maybe a benign prognostic marker for systemic lupus, and we've done some work on that. I'm just going to end a little bit on our registry. So since I've started about 11 years ago, we've had a patient registry that's been dedicated to cutaneous lupus, and this is I have a kind of I have a specialized autoimmune disease clinic where many of these patients have cutaneous lupus, and so we ask them to be part of this registry. And our goals are really to just see how people do over time. What are the things that by studying them over time, we can see how people typically do. Can we actually diagnose them better? Can we find potentially new treatments for cutaneous lupus? Because a lot of these patients are giving us actually blood and skin samples for us to be able to do some of our translational research work as well. So we have over 300 patients that we've had currently enrolled in our registry, and we typically try to get information information from these patients about once or twice a year. And so we had over 900 visits that we've accumulated so far. Most of our patients are actually African American, which has been kind of nice in terms of just the ethnic mix that we get in our patients. We do collect a lot of data from these patients, so typically it takes probably about 30 minutes to collect all the data that we need in terms of patient history, clinical data, so we also collect kind of disease severity assessments as well. We collect blood and skin biopsies if patients are willing to give it to us, and then we do extensive photographs just to document how people do over time. So some of the work that we've done is we've been interested in quality of life studies in patients with cutaneous lupus, and we've done this work with Vicki Worth over at Penn, showing that a lot of these patients who have cutaneous lupus are kind of probably amongst the most severely affected in terms of their skin diseases in comparison to other skin diseases. We've also found that people who tend to do worse in terms of their quality of life are female, have lower socioeconomic status and lower education level, and then increased disease activity. And the other thing that we've been also interested in is trying to develop a disease-specific patient-reported outcome measure for cutaneous lupus. And so what we've done is actually taken the Skindex 29, which was developed by MedCren, and it's a kind of a generic skin disease quality of life measure. But one of the sort of deficiencies of this is actually that there are questions that are kind of not present that are associated with things that are more specific to cutaneous lupus. So we've added, based on sort of focus group input, interview input, we've added kind of more cutaneous lupus specific issues like photosensitivity and alopecia to this measure, and we've published recently some of the validation studies with that as well. And then we've also looked at just how do people do over time. And so Vicki Worth and I have also looked at, for over 2 years, how do people do in terms of just standard of care therapies. And fortunately, most of the people either had improved or stable disease activity, but people who tended to do better in terms of disease activity tended to have higher, kind of worse disease activity at baseline and damage at baseline, and then interestingly, kind of a shorter disease duration as well. And then, so currently Vicki Worth and I, and this is what Dr. Friedman was alluding to, is that our current R01 study is actually now looking at, this is an observational study of patients who are on standard of care therapies, but really shortened, not from just 2 years, but now to a 24-week period, which is kind of more closer to a lot of clinical trials. And we're collecting this observational data of how people do over time to really develop. Our goals are really to develop control data that maybe clinical trials can use to compare how people do on their drug to just this patients who are on standard care therapies, as well as our goals is to develop kind of more standardized outcome measures for therapeutic efficacy, really to show what are the things that what people really feel, providers and patients really feel as adequate measures to show adequate thresholds that are used to be used for therapeutic efficacy. And so I just wanted to end again with just kind of talking a little bit about screening for SLE is really important, I think, for patients with cutaneous lupus because of the risk of development, as well as just this can be done through doing a good history and physical and lab testing. Again, I wanted to emphasize that antimalarials are good first-line treatments that we often use, and then can be used with followed by other potent immunosuppressants. And then there's, I think, really exciting new data that we are seeing with cutaneous lupus with new emerging treatments like anti-interferon monoclonal antibodies and lenalidomide, and that about 20% of patients up to 20% of patients can develop systemic lupus with people with cutaneous lupus. Any question? Yes.
The variety of ANA tests that are out there. What's your favorite?
Yeah, so ANA tests actually can come out in kind of a variety of forms. Like typically there's ELISAs, and then there's the which typically comes in a number, and then they have a range of like whether it's normal, borderline, or positive. I kind of tend to not favor that just because I think they tend to be a little bit, they're more likely to have false positives with the ANAs. So I usually probably more favor the indirect immunofluorescence versions where they give you a titer. Although sometimes you can, so there's a little bit more of a higher specificity with that as well. So, but I probably favor the ones that are done their titers. And there's a little bit of variance with that because sometimes there's, it's dependent on interpretation of signals as well with the labs too.
So if you have someone that's like, you really think that's what this, you send, a test off to either your own lab or request for lab. But if you ever switch and send like the advice panel, like a true IAM or?
So usually I think of so one of the things that with the IIF, or I guess if I think of someone really, really has lupus, one of the things I do pay attention to is just like how strongly positive something is. So if something is really, for systemic lupus, if it's really like in the range of 1280 to 250, 2560 in terms of that, that's pretty convincing probably for lupus as well. But if it's kind of in the lower end, like 160, 80 or so, it's harder to say. I think those are kind of a little bit more questionable as well. So I kind of really look at just the how severe it is in terms of how positive it is as well. That can be pretty helpful for that. So.
So much.
Thanks.